and we're going to get started. Our shift is going to be a little bit different because one of the last things that Ken talked about is we need to make things user-friendly, have a great user experience, sensitivity to the patient or the consumer. I will try as much as possible to completely throw out the word patient. I don't believe we should be talking about patients. I believe patients are passive, subservient, wounded, vulnerable, on unequal footing, and put in situations of enforced helplessness by the system. And yet we want them to change their lives. We want them to assume a culture of health. We want them to be adherent. I don't believe patients can do that. But people, on the other hand, can do anything if it's meaningful or important enough or matters to them. So it's got to be about the person. So it's all about the person. And as Ken said beautifully, it's really about the person's life. What we can do to make people's lives better, how to add years to their life and life to their years and save their life. With that, I have three wonderful friends and colleagues here who I've worked with in different ways and do work with in different ways. And I'd like them to share some insights of how we move away from this fixation on illness and disease to do things that make a difference in health. Now, I'll start with Amy. I met Amy when I got Fitbit invited to be with the Surgeon General of the Army. We were both part of the Telemedicine and Technology Research Command Task Force. And Amy was a stellar person there. And Fitbit was she's the number 3 employee with Fitbit, I believe 5, number 5 employee of Fitbit. But your timing wasn't bad, Amy, not bad at all. And Fitbit was really, to me, the first company that understood that if we really care about health, we want to make people more active, we want to make sure that people are sleeping enough, and we want people to be more mindful about a number of things. And they tried to make it fun rather than daunting. And Fitbit's taking a turn in the road towards expanding what they're doing, what their thinking is, and Amy will talk a bit about that. Then we'll talk about Arianpour with a company called Seqster, which is like off the charts way to get people's information in their hand and make a difference. Has a long legacy in genomics he'll tell you about. And then there's John Mattison. John Mattison is the youngest one in the pen. No, not maybe not. But anyway, John is a very good friend who most of the innovation that comes through Kaiser comes through his vision, got involved very early in the Human Genome Project, and is probably the most humanistically driven, thoughtful, expansive thinking physician I have ever met, anywhere, anytime. And just a real three charming people. Amy, tell me what you have to say here.
Good morning. Thanks for the invitation. Happy to be here. So just a little bit, I guess, about my role at Fitbit, because I think, as Dennis mentioned, we started as a consumer company, and most everyone knows us for kind of the wearables. When I started 10 years ago, there wasn't even a word for wearables. We had to kind of make that up. We were trying smart activity trackers, smart pedometers, and so the categories really grown over that time. The B2B business that I am the COO of now wasn't part of the original business plan, but within kind of the first 6 months of Fitbit talking about our product, it was actually a year before we actually brought the product out to market. Hardware's hard. We were hearing from employers, health plans, payers, others in the system who were looking to get validated data, looking to get better outcomes, looking to get better engagement. And so the B2B business was really born then, and we've really progressed a lot since then. So looking forward to the conversation to talk about really how we can provide that more proactive use into health for. We do think of them as consumers. We don't, it's not episodic care. At any time in your life, you're a patient, you're a provider, you're a family member, you're a friend, you're an employee, you're a consumer. And we really want to think about the person there. So thank you for having me.
Thank you, Amy. Thanks for being here. Ardy?
Thanks so much for having us here, Dennis, and for Stanford University to host us all. I'm Ardy. They call me Ardy, the one-man party. I'm a genomics ninja Jedi, so super professional, very informal. So formality just goes out the door with me. But
can I interrupt you? Would you show people your shoes?
Here are my shoes.
Okay, cool.
We just came back from health last week, and the first thing Dennis saw, he's like, "I want a pair of your shoes." I'm like, "Well, not yet, but you'll get one."
Stand up if you want.
Okay.
John will stand up. We all
I'll
believe
stand up.
sitting's the new smoking.
It's so true. So we have this little small company called Seqster. So a startup is like, 4 folks with an idea out of a lab. We used to be that long time ago. We're what I call a get-up. We just get up and actually just execute on really big ideas. And we've done this before within the clinical diagnostics and genomic space, within next-gen sequencing, moving next-gen sequencing to the clinic. And we became fanatic about all this data being siloed in various different places. And so we came up with Seqster. We were in stealth since January of 2016. Just came out of stealth February 28th. It's been 10 weeks. We've had an overwhelming response from both the investment side and partnership side. You can look us up online, seqster.com. And I believe that, health is the new wealth. And what a Seqster is someone who's been sequenced. A Seqster is someone who is looking to be sequenced, because most people haven't been sequenced, even though the direct-to-consumer testing is off the charts since last year. But more importantly, a Seqster is someone who's seeking more information about their health and their loved one's health. And we all want the security of their data. So very excited to be here to talk to you about how we bring all this data together in a common form and for it to live together in one place by creating the mint.com of your health data.
Stay up, you're not done.
Okay.
So Ardy was on the cover of Time at age 18, by the way. Tell us why, and tell us tell us how you blend together, and something about your background in genomics. Because what's exciting about what you do is the ability to bring together genomic data, what I get from my Fitbit or my Garmin or my whatever, and also some other stuff as well, and expanding that. It's like super cool, Ardy. When I first heard about what you were doing at Health, as you know, I called you up and said, are you really doing this? I've been waiting to see somebody do this for years. So tell them a little bit more.
Sure. I moved to the U.S. when I was 6.5 years old. I learned English when I was 9, a total underachiever. But like anyone, you have dreams that you want to actually kind of, make your stamp in society and move forward. So, when we moved here with $12,000, a family of 4, me, my dad, my mom, and my brother. Long story short, I got involved in just understanding a little bit about genomics at a very young age and biotech at a young age, because I grew up in San Diego. And so my first job was actually at the Salk Institute in Dr. Ron Evans' lab. He's won every award other than Nobel Prize in medicine. I was never smart enough to actually go get my PhD or anything like that, but I had a knack and a passion for the business side. I have natural business in my DNA. At the same time, I started researching various different companies, made my mom take $1,000 that I saved through birthdays and Christmas money and whatever at the age of 17 and invest it in a Charles Schwab account. Fast forward so that this isn't going to be some long-winded story that Dennis heard, most recently here. I made some picks on AOL boards, and then the editor-in-chief of Time magazine thought that I was some broker from Wall Street. My dream was actually to be a broker in Wall Street, but my dad thought that wasn't honorable, so didn't pursue that. So long story short, I went and studied biological sciences at University of California, Irvine, because that was the only school that I could actually get into. And long story on that is I got on the first cover of the Time magazine business section for point-and-click trading. And actually that moment means a lot to even this moment of me standing here in Stanford. I never thought I would stand here on stage talking to amazingly way smart people, way smarter than me, maybe not sharper, but way smarter than me in this room. That was really my first resume. In 2002, when I graduated, it was impossible to get a job. No one was going to give Ardy a job. But how I got a job is I told the people who were interviewing me that I could make you money personally. And they're like, how do you do that? And instead of having a resume, I'd show my Time magazine and the cover of the Chicago Tribune at the age of 18. And they're like, whoa, okay, that's pretty impressive, because what other candidates that I was competing against 30-year-olds. So I got into biotech and into pharma at that moment, at the age of 22, worked my way up and became an executive in my mid-20s, have been always fast-tracked. I'm 38, I feel like I'm 21.
Set is going to be critical. And then finally, I'm on the board of the Ontario Brain Institute, which is looking at all the neuroscience data, which captures what Len Dykewell was speaking about earlier, about preserving cognition in later life. That's the whole charter of the Ontario Brain Institute, bringing imaging and genomic data and phenomic data from all around the world into a federated infrastructure so that we can operate on that using machine. So the interoperability issues are still huge. The last thing I'll mention on the topic is I gave a presentation in the National Academies of Science, Engineering, and Medicine 2 months ago on the use of blockchain and homomorphic encryption to be able to facilitate some of this work. And so blockchain, people think is overhyped. Cryptos may be a little overhyped, but blockchain is not at all overhyped. And there are a lot of solutions in this set using blockchain to really have a secure ledger of transactions for everything that's ever happened to you in your health span. And homomorphic encryption allows you to operate on large data sets remotely without ever seeing the primary data. So you can get answers to questions that are very specific, very detailed, but don't even remotely risk violating the identity and the privacy of the individual's data that's held within that federated database structure. So between some of the elements of semantic interoperability that are emerging in different fields, the problem being too many, and the aggregation of data from multiple different sources, which as Seqster and others are doing at scale now, and the ability to operate on data without exposing the individual, I think the future is extremely bright for being able to do large-scale studies. The one other just sort of aside is that artificial intelligence is underhyped as well. People think it's overhyped right now, but in fact it's underhyped. And the reason I say that is that the emergence of AI finally in its third generation really is a result of digital exhaust and the quantity of digital exhaust, because any AI application is only as good as the training data set. And now that we have massive training data sets of digital exhaust, increasing by the day from wearables, from genomics, from electronic health records, the ability to have truly useful predictive value is very high. And there's, if you go to the classic journalistic frame of who, what, when, where, why, what AI can do very easily today is to match the universe of knowledge, the what, with the individual, the who. So I like to say population health is dead, long live person-centric healthcare and personalized care. So that why and what, and asking the question why to make sure that it's relevant to the human experience, and the what and the how, the matching of the knowledge universe of the individual are really important. And then I like to think of meta-AI. And meta-AI is where you actually take the match of the what with the who at a personalized level, and you ask when and how do you deliver that. And I like to think of, instead of a drug formulary, a motivational formulary consisting of motivicons, not emojis, but motivicons of various forms that help motivate people, because the explosion of knowledge in behavioral economics and motivational science has just barely begun to impact the healthcare field. What B.J. Fogg has done, and what Danny Pink has cataloged in his book Drive, I think are foundational in our understanding about how to take the benefits of matching who and what with when and how. And that, I believe, is going to have a profound influence about how we motivate people to achieve their personal goals, for changing their lifestyle, to avoid the disorders of lifestyle that lead to all those morbidities that cause unhealthy aging and a persistent gap between the health span and lifespan.
So I'm going to throw this open to the audience, but I'm going to do this by asking two people in the audience questions that I know can add to this conversation. First, Bob Rowley, you're on, and then next, Pat Dunn, you're on to respond to this. Bob, would you like to share anything? Let's get him a mic, please. There we go.
Well, I'm fascinated because in the work that we do, which is sorting people on their biologic instincts, everything ties back to context. So you need a strong base of integration of data and information to answer that other question of why. So So if we're getting into personalized motivations, how do you see these kind of integrated experiences starting to evolve and productize, really?
Yeah, I just led a work group at a very interesting offsite in Carmel 2 weeks ago on exactly that topic. And the example I like to use is 1,000 times a day, a 45-year-old woman walks into her primary care doctor's office and is newly diagnosed with hypertension and type 2 diabetes. And the physician can turn to them and say, well, you've got 3 options. You can take these 2 drugs and come back in 6 weeks and get a blood test and your A1C. Or you can radically change your lifestyle and you won't need either drug. You just need to follow those 4 principles of diet, exercise, sleep, and social resilience. And we'll get you back normotensive and without diabetes. And there's abundant evidence you can do that. And the third option is somewhere a combination of the 2. And the woman says, well, the reason I've got hypertension and diabetes is because my daughter's getting married in 3 months. So I want option number 1, give me the 2 drugs. I have no bandwidth to change my lifestyle right now. But I want an appointment in 3 months and 2 days when I get all the in-laws out of town. And I want to come in and I want to go for option number 2 and I'm going for broke and change my lifestyle. So the talk that I gave, the presentation I gave in Carmel 2 weeks ago was about how we need a market, to your point, of artificial intelligence services. So when we all retain the data in Seqster of ourselves and our family, you know, by the way, the DNA of your parents is really relevant to your DNA and disambiguating what's impactful and what's not. So I love what Seqster's doing.
Thanks.
But I think that we need to be able to very quickly ascertain, and I think there's some very good ways to do this, again, with AI. What are your personal values? What are your personal objectives? If you ask 5 people in the same family what their values and objectives are, you're not going to get the same answer. So we start thinking about, you know, the context being age, gender, ethnicity, income. That doesn't even come close. We need, as the work that you're doing, very personalized surveys. They need to be very low overhead and very validated. Then we can match the what and the who with the why. And the why is what motivates you? What are your priorities? And this is different within individuals in the same family, as I alluded to earlier. And so to the extent that we can efficiently and effectively, using validated surveys, know how people want to sequence and prioritize their own health activities, we can then support it. And so the punchline of the talk I gave in Carmel is that we need a marketplace of solutions that is very flexible and adaptive to the why at an individual level.
Yeah, just to add on to that, you know, we think the silent killer in all this, or the unseen risk, is the whole construct of ambivalence.
Yes. Well, as Patch Adams said, that we need to stop thinking about diseases, we need to think about health, with one exception. The worst disease in the world is indifference.
Absolutely.
I have a couple comments. I think we can all relate to this. So how many people here, you know, are healthy? Raise your hand. Okay. So I look healthy, right? I weigh 175 pounds. I'm running a marathon in 2 weeks. I'll, you know, bet my mic that no one can beat me around the block, even if you're 20 years younger. Because I got the Actin 3 gene and I was an all-American sprinter, track and field, yada, yada, yada. But I'm not going to be healthy one day. How do I know that? Because I've had my whole genome sequenced. And again, like I said, disease runs in my family. One day, I'm going to get hit with something. And my whole point is, we all walk around thinking we're healthy. And we are. But at some point, if you live long enough, like my 92-year-old grandmother, or my 88-year-old grandmother that passed away from Alzheimer's, we're going to die, obviously. We're not going to live forever. So I have this thought where I don't think we actually care about our health. I think it's bullshit. And I don't think we care about our health until we're sick. And that's why, you know, the key thing is, if you can actually have, just like, you know, we take care of our finances, right? Our money. If you see your dollar go down in your Wells Fargo account, or you have a fraud alert, you get like a call from your credit card. We care about our money so much, even though it has zero value. It has some value, obviously. It can help pay for your medical.
You can buy Bitcoins with it.
Yeah, you can buy Bitcoins or whatever you want. But what I'm trying to say is health is really the new wealth. And I think as a society, we're starting to understand that if we put on a Fitbit, if we put on an Apple Watch, if we put on a Garmin, if we do get sequenced, if we do 12,000 steps a day, the 10,000 steps is, forget 10,000, you got to do 12 to 15,000. This is what I was telling my mom, but she only makes it to 6,000. It's good enough, it's good. But what I'm trying to say is, the whole thing about health is about actionability, and you don't really take action until you are sick. You don't care about your health until you're sick. And that's really the essence of, I think, so many different things. So if we can have a dashboard where, just like Mint.com, you get to aggregate your Wells Fargo, your Bank of America, and student loans, and then see what your net worth is, why haven't we had a dashboard for our own health? Because as a healthy person, I'd love to see my longitudinally matched blood pressure correlated with my analyte from ABC, and also what SNPs I cover with an integrated view. That's what Seqster is all about. I'm not here trying to sell you guys Seqster. I'm actually trying to preach the fact that you are all Seqsters and you didn't even know it yet. But after today, you'll think about it, you'll get the bug, you'll look it up, and it's because you are healthy, but one day you're going to be unhealthy. And so to care about your health is to care about it yesterday, not today.
Thanks, Ardy. Pat, do you want to share something or no?
Sure. So Pat Dunn from the American Heart Association. I've had to kind of traverse my question through these comments, which are all very good. I do completely agree that the social context, it matters. And we're really focusing on, frankly, the why, and not just the who and the what, but the why and the how. And if we can figure out the why, it's much easier then to help the person with the how. And there's multiple ways to do that. I also agree with your statement that a lot of us, you can have the I feel fine mentality. You can I feel fine, and at lunch you can have a heart attack and die. So, and that's not, I don't know that it's much about just ambivalence. It's, people don't have enough information to know that they're not going to be feeling fine 5 minutes from now. So my question is, for all three of you actually, because and I also think that we sometimes disserve patients, by thinking that they don't care, they're uninterested, that health doesn't matter to them. I think it's really on us as healthcare professionals and technology providers to give information both to clinicians and to people/patients so that they are compelled to act. And frankly, even the payers, that they're compelled to act enough that they're going to pay for it. So how do we measure that in a way that's scientifically acceptable but still adds to all of these nuances of the social condition, the social context, etc.?
Let's start on this end, please.
Sure, it's a great question. I think at Fitbit in general, we believe that we should move from episodic care or episodic incidents to kind of streaming physiological data at all times, right? So we have the ability to do that. We have, heart rate, which used to be only accessible by wearing a chest strap and was really for folks like us who are trying to run a marathon, versus your everyday person who doesn't even understand, why heart rate's relevant, and that you could maybe lower your resting heart rate more quickly than you can see pounds fall off a scale, right? So I think that part of it is taking data, making it actionable, making it meaningful to the individual, and kind of just translating it for them. So a part of it is education and awareness about what metrics they need to know, and then making it actionable for them to be able to do something about it. So easy to measure, easy to act upon, to then be able to enact that change. Now that said, the behavior change part is still hard, and that's where building the social, it's easy to say, it's harder to do. And so having your kind of social network and making the data easy and accessible. I love the idea of a dashboard. That's something we talk a lot about it, that you have your like red, yellow, green, you know, where are you red, where are you green, and kind of your alert system going off, right? There's 10,000 of them in a plane, there's a ton of them in your car, and there's many less about your body. And so I think that's really what it is. It's taking those data points, it's making them actionable, easily accessible, and then translating them of what's next, right? And I think that's where we really see that going. And I think the last thing I would say is just, it's moving from, it's kind of like that Know Your Numbers campaign that everyone has done for several years. There might be new numbers we need to add to that, and it's not a number that's once a year that you go either to your physician or your health screening at work or you get your blood draw. It's how do you know how that's changing every day and continuously, and that's where we go back to that streaming like physiological data.
Ardy?
I think, you know, we try to take like an approach where what can we do today, right? Because as you guys have mentioned in your talks today, there's just so much, it's mind-blowing, right? When you think of like our solar system and then you go outside our solar system and then you go outside our galaxy, it's like, whoa, you know, your mind just blows away when you try to do this on the data side too, right? I love comparing it to astrology or whatever. And so I think what we can do today is taking a look at family history of data. And how many times have we gone to the doctor's office and we actually put the wrong stuff? You don't know what your grandma had, you don't know what your dad had, you don't know what your mom had. And I would say probably 50% of this room still doesn't know what your family history is. So just a personal experience. When we were building Seqster was able to launch about a year and 3 months ago, but I stopped it because my 92-year-old grandmother passed away. She rose me when I was a kid. She was my #1 fan. When she passed away, no reason to be sad, it just happens, it's part of life. It's the fact that she passed away without passing on her health data to me, my brother, and my mom, the alpha daughter that was a caregiver, okay? So we would have been a nice family cohort because we have, you know, disease running in our family, cancer, Alzheimer's on both sides, APO1, not APO2, thank God, and so forth. So, you know, nice little small family to study. How does a pharma company or a therapeutic company find the Arianpours? That's a really hard question, right? That's a $100 billion question. And so there is no system for us to get connected to be able to contribute our data to society. And we're talking about this whole common good conference. That's what this is all about. It's not about being healthy. It's not about getting another Fitbit or another, you know, wearable or whatever. It's not about, you know, getting sequenced. It's about all of us helping each other with our health data. That's what we're interested in. You got to be really mission-driven to understand the significance of data, actionability, and how you do that with families. So going back to the grandmother example. So when she passed away, unfortunately, without passing on her health data to everyone in this room, to everyone in this city, to everyone in the state of California, to everyone in this country, to everyone in the world. My grandmother's data had value for everyone, and so did yours for my family. Now we understand the significance. So I think today what we can do is actually preserve and pass on our health data. Because if I walk outside and I take my Uber before I get on my plane back to San Diego and I get hit by a truck and I die, my data's gone. It's deleted. You can't retrieve it. And that is really big. I think that is something that we can actually do today. And there's various ways of doing that. And it's not something easy. There's got to be collaboration between academics, commercial folks, payers, you name it. You know, the dark side and the Luke Skywalkers, right? We got to all come together to be able to solve that big problem. And if we do that, then we help our children's for generations to come. To me, that's actionability.
Do you want to add anything or no?
Yeah, a couple quick things. Great comments. I was on Health and Human Services Innovation Board about 5 years ago, and we were looking at various proposals. And the one I liked the most, but didn't make the cut, was to, how you can get an organ donor on your driver's license is to have a comparable data donor on your driver's license for precisely the reason that Ardy mentioned. Second thing is about astronomy and all the big data that came. That was sort of the original source of big data. Alexander Solly at Hopkins University, who's still very active in his 80s in the space, will tell you in a heartbeat that getting standards around data, even in the map of the universe, was much more of a social challenge than it was a technical challenge, and that's true of everything in the interoperability space. Mention of the ApoE4 and its impact on Alzheimer's disease. If you don't have an ApoE4 allele, your risk is about 6-7%. If you're heterozygous, it's about 12%. If you're homozygous, it's about 17%. Well, that's not all that impressive. It's one of the best markers we have. But what about the other massive amount of people who get Alzheimer's disease with aging? What's going on there? And we now know that there's over 1,400 SNPs, or single nucleotide polymorphisms, that are associated in a GWAS study, a genome-wide analytic study of tens of thousands of people, that there are thousands of other genetic permutations highly associated with Alzheimer's. So where's the signal and where's the noise in that? We'll know soon. There's also very promising news about the use of a particular type 2 diabetic drug that's already approved by the FDA in not only arresting but reversing Alzheimer's and memory issues, reversing memory issues in the mice model so far. And there's another small molecule I'm under NDA, but very, very, very promising stuff in the Alzheimer's front. The sparse matrix issues that you referred to in terms of, we'll have a hemoglobin A1C done 2 years ago and then a year ago, or a thyroid stimulating hormone, or various markers of health. It turns out that there's a new technology emerging out of UC Berkeley called massive convolutional neural networks that accommodate the fact that data in health is very sparse. And will probably always be very sparse to some extent. It's declining, but being able to interpret those data when you only have a few data points, particularly when we know the circadian rhythm has such a profound influence. So if you measure a lot of these biomarkers at different times of the day and say, oh, that's what your biomarker is, well, if you don't have it in a circadian context, you don't really know. And I attempted to file a patent in this space 5 years ago, but it was already taken for using circadian data about individuals to create a personalized nomogram for each individual based upon their circadian rhythm, so that you would know what you were measuring based upon the time of day. The last thing I'll mention is that GINA, the Genetic Information Non-Discrimination Act, was a profound accomplishment, and it prevented discrimination based upon genomics for your health insurance. What it did not do, very deliberately, was take on the lobbyists of life insurance, long-term care, and disability. So today it is not only illegal, but it's being practiced by life insurance companies to ask if you've been sequenced, and if you have a BRCA allele that's pathologic, they'll redline you. If you deny that you've been sequenced and they find out later that you are, you're wasting your life insurance money, because they'll deny it later, finding out that you've been sequenced. So the notion that we can, and there's a lot of discussions, I'm on the NIH Policy and Ethics Board for Medical Information Commons, and there's still talk by some quarters from researchers saying we need to use conscription, say you must contribute your data for the public good. This is a classic philosophical debate of the good of the community versus the good of the individual, that you must give your data for the benefit of the community. Well, in the EU, that's just fine, because they don't have the problems we have here of legal discrimination for life insurance, long-term care, and disability. They don't have that problem that we do here in the U.S. So we need to solve that problem so that conscription is much less of a threat, and people will gladly volunteer their data for research purposes.
Two last questions. Ken, please, and then you, and then we. Mike, come up here, Ken. Just walk up here.
I can do this. Okay.
Give him Mike.
First of all, thank you. You guys are pretty amazing. Here's my question. There's a lot of sensitivity these days to inequality. And we know currently that the top decile financially of people at the age of 50 have a 14-year higher life expectancy than the bottom decile. That's at the age of 50. And we live here in the Bay Area where we all know that people of great means are buying blood and they're injecting hormones and they're doing all sorts of provocative things with the idea of increasing their health, well-being, longevity. Where are we heading? Are we heading to a world where there will be an elite population that will be managing and tracking and taking action, and most other people will not?
On response, John?
Yeah, I like to, I've given a number of talks on the ethics of AI, and there's a couple of great books on this topic. If you haven't read Weapons of Math, M-A-T-H, Weapons of Math Destruction, I highly recommend it. It's precisely this point. There are 4 types of bias that occur in machine learning, and I won't go through this in the interest of time, but what we neglect is the fact that I like to think of machine learning as thinking in silico, and what our brains do is thinking in carbon. And there are entire textbooks of the scores of types of cognitive bias that we all suffer from that are not taught in medical school, that are not taught in wellness programs. And so I see the future not as a singularity, but as a dyadarity, with a meshing of the thinking in carbon and thinking in silico. And so how do we build transparency into the biases of cognitive bias, well researched, but poorly implemented in terms of education. And now we're opening a new Pandora's box of the intrinsic bias of machine learning. And so what I see is a meshing of those two in a dyadarity between the machine and the human, while exposing the unique and exposable biases inherent in both thinking in silico and thinking in carbon, so that we can address those issues of social inequity that are amplified by many of both the biases in thinking in carbon and thinking in silico. So when we really explicitly expose those, we have the opportunity, as Alfred Deming once said, if you don't measure it, you can't change it. So we need to measure it, expose it, and manage to those biases so that we minimize. There's always going to be a wealth gap, and there's even a paradox in abundance itself. But to the extent that we measure and expose it, we can manage it.
Excellent. Final question.
Scott Mace from Health Tap, and my question has to do with Seqster, which clearly is a very promising platform. But if I have a mother or grandmother who releases her genome into public domain, essentially, and maybe there's a family member, a relative, a niece, a nephew, someone who's not so cool with that, because now the forces of big data can harvest that information and now create a profile of them that they never sought to have created in the first place.
And you can identify the Golden State killer.
Yeah.
Exactly. So how do you aim to try to deal with that issue, which is sort of a new twist on the privacy issues?
Very good question. I'm a fan of Health Tap. So obviously a lot of this stuff is coming, the whole Facebook stuff is coming, and then this new genetic criminal, as we call it, is coming to fruition here. I think it starts with, obviously, transparency and privacy from the front. You have to understand, most of these companies before, when they created their platforms, they didn't start with that very essence or ethos of that being the company like baseline. That's number one, right? So for example, your Facebook pictures are paired with your name, right? And I can hack into it and know exactly where you were in Hawaii in 2006. But the reason why it's like that, and the reason why it's going to take a long time to change, is because from the start they did that. Now on the genetic front, obviously there's lots of more sensitivity. Now there's various ways where you can actually encrypt that data from the start. However, that being said, how we deal with it and how we're dealing with it today, and I'm sure we're going to be dealing with it, differently tomorrow and so forth, is the fact that it's consented, right? So if I consent and my grandmother consents, and that's my grandmother and that's my data, because by law, you own your health data. The health system doesn't own your data. Fitbit doesn't own your data. 23andMe shouldn't be owning your data. No genomic lab should be owning your data. Your grandmother, your mom, your family's data is your family's data. It's no one else's. It's kind of like your flesh on your skin. And so, you know, I think as long as there's full transparency as to what's happening between you and the party, which is your family, of creating that multi-generational health record, and if you guys decide to share that on your terms, then I mean, if you decide to go walk outside the street on the 101 and get hit by a car, that's your problem, right? It's not anyone else's problem. If you get in a car and you go 65 miles an hour and you follow the rules, you're great. Now, with the genomic data, obviously, there is some way to actually encrypt it, and I think that's where, I'm not going to go into it, but blockchain comes in to very, very, you know, handily, you know, hide various different things that you would not be able to find, and I guess that's basically it. Yeah.
Thank you all. We'll be around informally to answer questions. We'll be following up on some of this stuff with other panels. Thanks again.